A very, very warm welcome to everybody here sitting in this hall in Goa, enjoying the sun and sand. But let me now take you to Jaipur straight away. And here we have a fantastic operator, which is Dr. Ravinder Rao. Everybody knows him now. And he's one of the finest structural heart exponents in India and, of course, well known abroad. And he's going to share with us a case of MitraClip, which is very, very, well established now after the co-op trial. And of course, we will see the nuances, the steps of how a MetroClip is done, and he will show it to us from step to step. So, very warm welcome, Ravinder and your team over here. And we have now on the panel is Dr. Kashish, and Dr. Kashish is again a very, very serious operator on TAVI and MitraClips, and he has done thousands now. And he is now going to present the 5,000 patient study in ESC in 2 days' time, and which I don't know whether he will share with us the data or not. But no, we are very much interested to have him here because he has so much experience. So we will have to learn from him a lot in terms of this MitraClip from step to step. And also, we were waiting for the great Gatsby, Dr. Saibal Kar. Dr. Saibal Kar is he is the claimed Badshah of MitraClip, I must say, in the Indian terms. And he is here. So thank you very much, Saibal. I know you are extremely busy. And of course, you are almost lecturing every half an hour to the entire world. So thanks for giving us this time. And of course, we will miss you in person in Goa.
I know, I'm sorry.
Yeah, no problem, no problem. Your ghosts are moving around everywhere. Okay, so thank you very much for being here. And I'll request Ravinder to start the case and take us forward. Thank you.
Welcome all. Thank you, sir, for those kind words and introduction. And thank you, Dr. Sabilkar, for agreeing to moderate this session. And thank you, Kashish, again for to moderate this session. So we're going to go start with the case presentation. Next slide. Next slide. That's our team. That's me, and here's Dr. Kailash. He's also an intervention cardiologist trained in structural from Italy. Dr. Prashant Varshney, he's a cardiac anesthetist trained in D for MitraClip. Dr. Govind Sharma, again an intervention cardiologist trained at German Heart Centre, Germany. Next slide. Our patient is a 78-year-old male patient, height 167, weight 82 kilograms, BMI 29.4, body surface area 1.9, NYHA class 3, history of CAD since 2006, had a bypass surgery in 2019, Lima to LAD, radial to ramus, OM1, OM2, a vein graft to PDA. Had a CHB in 2018, underwent a dual chamber pacemaker, recent onset AFib since July 2022, got admitted for recurrent heart failure in past 1 year. At present, he is on ACE inhibitor, diuretics, Codron, Eliquis, and a beta blocker. Next slide. These are the hematologies. Creatinine is 1.5, NT-proBNP 2024, EKG shows AFib, intermittent V pacing. STS score for mitral valve repair is 6.94, Euro score is 15.56. Next slide. 2D echo, transthoracic echo done outside shows an EF of 35 to 40%, ruptured chordae, flail AML leading to severe MR, RWMA, akinetic posterior wall, mid-basal inferior wall, jerky IVS, LA is dilated, LV normal in size, normal RA RV size and function. Next slide. TE again shows an A2 flail with ruptured chordae, severe eccentric MR with posterior directed jet. Mitral valve area on TE is 5.8 centimeter square, flail gap is 4, flail width is 8 mm, mitral valve gradient baseline is 2 millimeters, annular calcification is present, mild pH. Next slide, please. And these are the echo pictures. You can see a flail segment of the AML with a chordae which is going into the LA in the LVOT view. There's a BICOM view again. We can also discuss the echo live. Next slide. And you can see the videos. Next slide. Next slide. Next slide. Severe eccentric MR, 4-chamber view, 0 degree. Next slide. Next slide. And you can see the go back. We want to show the pulmonary vein flow also. And you can see the systolic blunting of the pulmonary vein flow. Next slide. Next one. Next. Again a 3D TE picture. Play this, please. and you can see a flail AML segment with prolapsing of the chordae into the LA. Next slide. Severe mitral regurgitation. Next one. So MitraClip under TE guidance and fluoro guidance, general anesthesia, we can discuss what to do with AFib and the MitraClip position, re-SSMR post-procedure, and these are the things which we're going to discuss. Next one. What clip to use, NT, NTR, XTR, NTW, XTW, all these things which we can discuss. So I think with that presentation, elderly patient, 78-year-old post-cabbage, clearly not a candidate for a redo surgery. We have selected this patient for a MitraClip procedure. Over to you, Praveen Chandra sir, Dr. Sabalkar, and Kashish. So what I have is I have a 6 French sheath in the right femoral vein, an O32 wire. I've selected an SL1 sheath to do a septal puncture and a BRK1 needle.
Okay, so thank you, Ravinder. I think this was wonderful. By the time you are putting up the sheath and the wire, etc., ready for puncture. So let me take the first comment from Dr. Saibalkar in terms of this case selection and the selection of clip. Saibal.
So I think it's an excellent case to be done. First of all, he's definitely high risk. He's got previous bypass surgery, moderate renal dysfunction, and he's got LV dysfunction with DMR, which is actually really bad because he's got a flail PA2 and a LV dysfunction, 35-40%. So putting it all together, this patient is very high risk for open heart surgery. Also, the repair rate of a patient with flail A2 is not that easy when you have low EF, because this is like a mixed pathology. So this is a great case. Now, putting it from MitraClip tier standpoint of view, it's also a great case because it's a localized area of pathology. You see a localized A2 flail, and the rest of the leaflets are normal. The posterior leaflet is slightly restricted, and these candidates actually do very well with edge-to-edge repair. Regarding the clip size, usually for DMRs, I tend to use the longer clips. I use XT or XTW. The only issue I have is the posterior leaflet length. The anterior leaflet is okay. If the posterior leaflet is greater than 1 centimeter, then I would definitely use an XT, and most likely with the valve area of 5.8, I would just use an XTW.
Yeah. So,
Okay.
Yeah,
Ravinder.
So I think maybe we can discuss more, but that's what we have selected here. Prashant can do a live measurement of the PML. So if you allow, can we go ahead and start a septal puncture?
Please carry on. You
Okay.
keep working.
Okay. So this is an SL1 sheath. We're going to come down. You can see the bicable view. Can we have the echo pictures, please, in front of the small slave monitor? Yes. Okay. Okay.
And then in my practice, where we use Baylis, the dilator bends
so
like the way you bend the needle. So I just bend the dilator more.
So I'm going to come down. So I'm clocking and I'm coming down.
Yeah, the only thing is with the cut, Bowie cut 30 or maybe you can take 35. So we do for the trans cable also. It just
can you remove this
it's
swan,
like a
please?
butter, knife and a butter.
Yeah, that's great.
Okay.
Take your posterior there, just take that and then measure it in a different view.
No,
by the time
show
you
your short axis.
Okay,
yeah,
short
just take
axis.
the posterior.
Okay, good. So we remove the swan for the time being because it was coming in the way. Okay, let's look at the septum again, please.
Counterclockwise a problem. I just can't see the tenting.
Yeah,
maybe jumped out.
Even I can't see the tenting.
Maybe it's too posterior.
Yeah. Very good. It's a great position.
Explain it. Okay, that's the
yeah, it's mid.
That's great. Just take it.
Stay live on the echoes, please.
Yeah, we don't see the.
Yeah, there. Okay, still in that same position, so that's good.
Show me short axis once. Oh, good.
Okay, so let's see.
When was the posterior toss?
Okay, give me some dye, please, here.
I think you're through, right?
Yes.
Yeah.
True.
Yeah.
So I use that. I'm gonna go ahead and advance this thing. Okay.
Did this patient have a septal repair or something? So weird that
No,
they
I
use
don't
it.
think so.
No.
Very high puncture.
It's
Okay.
very high. Yeah.
Yeah, it's close to the high part of the fossa.
So the
Okay,
only
just remove
patients we
this.
bridge are
Careful with
either
the
they have
wires.
super like
Put
hypercoagulable
the
disorder
stiff wire.
where they've developed
Or,
PEs and
or
stuff,
there is a or there
or
is a
mechanical
mechanical
valve.
valve in the
Yeah.
aortic position. Yeah.
Yeah, mitral position.
But what is the stroke incidence in in your MitraClip experience? Let's put a 4 French pigtail, please.
It's very low clinically, but when you look at national data sets or even
Put a
trials,
pigtail
like
on
they
the
still report
035.
like 1 to 1.5%, which it's I don't know why we see it. It's probably just every time you go puncture, even in AFib ablations, they have shown there is a stroke rate. So every time I think we
So we're
enter
ready
the
with the
LA,
guide.
there is a small risk.
So the clip which we have selected for this patient, as we discussed, is an XTW clip.
Sometimes these patients start developing a gradient, so that is why we have to be little.
Yes, and that four is when the patient is under general anesthesia.
Yeah. Three. It was coming to
Yeah,
3 and 4.
yeah.
So we were.
So one of the things, so Everest trial, the cutoff was 4 for valve area. It was not 6. And actually, in the US, we use 4 as a cutoff for valve area for most of the clips. It's less than 4. But when we look at our TMVt registry, not the data I'm presenting, but primary MR data, actually, there are a lot of patients even less smaller than 4 that are getting clips in the US with not very high gradients. I think, but we end up using NTs in those patients. And majority of the times, when we check a gradient after that, it's high.
Go to a scale of 50, please.
Because
The guiding
usually the
catheter.
mean pressure shouldn't come up. Unless the
That's
patient's
true.
blood pressure has gone up.
Yeah. Okay,
And
so we're going
sometimes
with the guide.
Sometimes the anesthetist starts giving some inotropes or some
Yeah.
heart rate goes up, then also the gradient goes up, and then you reduce the inotrope, the gradient goes down.
Yeah, like this patient looks very tachycardic.
So can you see the hemodynamic tracings? You can see the pressure which is coming from the pigtail in the LA. A large V wave of almost. Let's come first. Come here. Don't worry. Come here.
Yeah, how high is the LA V wave? It's 45.
Can you see on your screen?
We can see the. I can see in the. Oh, there. Yeah, that's nice.
Okay. So hold the guiding. So this is a guiding catheter. So you put negative on it, make it straight, and we're gonna go ahead and enter. Okay. Hold the wire, please. Okay. Hold it here. Just rotate a little bit. Yeah. Okay, there it goes. Okay, Prashant, so we're gonna come up. Hold the wire, please. Show me the guiding catheter. Okay, so we're gonna make it neutral here.
I usually counterclock a little bit as you come through the septum. It will make you go anterior as you're crossing the septum, and then take the negative off once you're inside.
Okay, give me a rail.
Pull the wire back a little bit.
Yeah.
Okay, right there. Hold it like this. So just pull the wire back.
Yes.
Okay, so Prashant, short axis. And then the other question is, do you dilate the septum before going with a guide, or there it jumped in? Okay.
No. We
Almost
don't.
never. Almost never.
No need to, yeah.
Yeah, so that's
We
same
have
thing.
this habit of dilating the septum, but there is no need to dilate.
Yes. So the guide is in. Prashant, can you measure the guide, please? Okay, so we're gonna dilate.
Now the dilator is out.
Back.
It's still far away. Yeah.
Still quite deep inside.
Yes.
Yeah.
So I pull back the dilator. The wire is still there. Okay, Prashant.
Yeah,
measure
still
it
have
out.
a guide.
Okay, so I'm gonna pull back the guide. Yeah, we are too deep into the LA, so I'm gonna pull back. Just focus on the guide. Yes, that's a good view.
This is better.
Yeah.
Oh, even more. You
That's all. That's all.
Okay.
That's
So
all.
measure the guide, please. Okay, so remove. So we're gonna go ahead and remove the dilator and the wire. So as he's removing the dilator and the wire, I'm doing a suction, the negative on the syringe, and put your thumb as soon as it comes out.
Ready with the thumb.
Yes. Okay. That's it.
So Saibal,
Do an
is
ACT now,
the
please.
are there any instances when air gets sucked in? And can you tell everybody about how to prevent that air embolism?
Do an ACT, please.
So this is a very important aspect of the procedure that when you're putting the guide in, make sure that the guide is not touching the wall.
Wall. Yeah.
Because if it touches the wall,
XCW, please. Go ahead.
then you will not get you can cause a suction and you can get air entrailed from the hub. So you make sure that like this, you can clearly see the guide. And then if you aspirate gently and you still seeing blood, you're fine. So that's how you prevent.
Okay, flush, please. So, I mean, just for the people who want to understand, there's a blue line to blue line, please inject. Yeah, okay. Wait a minute, don't rotate. Yeah, I see that. Okay, blue to blue. Okay, so the clip is coming, Prashant. So the guide depth is just 1.3 millimeters to 1.3. Okay. Okay, short axis, Prashant. Okay. So I'm going to pull back a little.
Yep, pull the guide back and go anterior or posterior to
And
kind of get
go
into the P vein
anterior.
almost.
Okay. Let's see the tip, Prashant. So I'm going to try to straddle.
So go posterior, actually follow the pigtail because that's going into the P vein. Then you'll have room to
See.
go in.
Okay, Prashant, show us the tip.
Pull the guide back a little.
Yeah. So I'm going to go ahead and advance more and try to straddle this.
Yeah. Now just give M.
Okay, so that's our straddling. We're going to give M here. Okay,
Pull back pull back the system, right?
Yeah,
The DC handle.
I did
good.
that. Just pull back the DC handle. I'm going to straddle a little bit more.
Yep,
There.
that's good.
Actually looks pretty good height wise and everything.
Okay, Prashant.
Explain that. Can't explain the bicommercial view. See how it's a wall hugger?
Yes, it's coming close to the aorta.
Yeah. Because of the anterior puncture.
So give plus to the guide.
Yeah, I'm going to give plus to the guide. Okay.
Go anterior.
Okay.
You're very far inside.
Yeah.
Bring your weight posterior.
So I'm going to come
I
anterior.
doubt it. Yeah. Yes.
Yeah,
Okay,
so
good.
I was.
So
So
come back.
I came anterior.
Very good. That's
Okay.
it. Great. Now take it. Now open the clip.
Okay, so we're going to unlock the clip. Do you think we should assess which is anterior, which is posterior after opening? Okay.
Yeah.
Oh,
Of
yes.
course.
Okay. Okay, so we raise the grippers, we unlock the clip. We're going to open the clip. Okay, Prashant, just focus on the clip arms.
It's opposite.
3D and face.
3D and fast, please. So this trajectory, you think it's
So for everybody's understanding, let me just tell everybody that now is it's an interplay of the sheath movement, the whole device, and there are certain knobs, which are the movement knobs, which will help us actually position the clip in the proper position.
very
very
lateral,
lateral.
very lateral.
It's a good position.
Yeah.
No, that's fine.
Yeah. And we're gonna feel the tactile feedback. Okay. Prashant, go to the LVOT view.
So that was anterior, the one that you had
Just
just
go
now.
to the LVOT view. Yeah.
Yeah.
So that's the interior. You can see how the gripper moves. So I'm
So
gonna
is that the tactile one?
yes, that's the tactile one.
Okay.
Okay. All right. So we have identified the anterior, posterior. Okay. So I'm gonna close the clip arm a little, 60 degrees, and we're gonna go. What's the tidal volume?
So Dr. Kar, why did you adjust the tidal volume for everyone?
You decrease the tidal volume because the movement then decreases. If you increase the tidal volume, the clip and the valve keep moving. So that's why.
Yeah, that's why sometimes you have to hold ventilation while
Yes.
going in, especially for a second clip. But holding
That's
ventilation will move you medial. So that's one of the things with tidal
That's
volume
why
too.
that if you decrease the tidal volume, the overall excursion is less. So you see you gone to medial.
Yeah. So I'm
So
gonna
take a
decrease.
little-
Yeah, I'm taking the M off.
Yeah. So yeah, holding ventilation and reducing tidal volume makes you go medial.
Okay, Prashant. So we're gonna go down. Okay, so we're gonna open the clip here. So I'm gonna open the clip arm. Explain it, Prashant.
Color off.
Yeah, I want to see the flail in that view.
Okay, good. Very nice.
Yeah. So I'm
Now
gonna
you can slowly come back.
I don't see the flail though, Dr. Kar, in that grasping view.
Yeah.
Do you think it's spinning?
I wonder whether it's stuck on the thing.
Or is it pinning, or are we not in the right spot?
Either of
Because
them. will be
there
true.
you see the anterior leaflet coming down, but you don't see the flail going up. I don't think it's the right. It's just medial
up.
to it or
so I'm gonna
lateral.
pull back.
Yeah, but he's correct. He's in where the hell is the
Flail.
flail?
So
Yeah.
probably it might not be going to the LA because the clip might be holding it to the LV side.
No.
3D and fast, please. Prashant.
Yeah. Let's just see where we are. There you see the flail. Actually, I saw
Yeah,
it for
yeah.
a second. I think it's behind the mandrel.
Behind.
That's what it is.
Go, come-
Behind
come
the
back, pull
mandrel that's
back.
connected to the clip. Yeah, keep coming up.
So I'm gonna pull
Pull.
back.
Very
You
good.
can see nice. I can see AML, PML resting on it. Drop the grippers, please.
Pull out a little more and you drop it. Good.
Okay. So you can see the bounce. Close it to 60.
I would always see the orientation at this spot. I usually check orientation.
Okay. That's it.
On 3D.
Yeah.
3D and
Drop the
face.
clip. That's okay. Now we wait. Let's check the orientation.
Yeah,
So
don't close the clip. The posterior may have come out.
Yeah, the
Clip is completely rotated wrong.
let's look at the orientation, Prashant. I think.
no, we're about 11.5.
Yeah, 11.5. Yes.
Counterclock.
Yeah. Or just maintain this. Maintain this view. Okay. So I'm gonna open and go down a little. So okay, let's go to the 3D. We need to look at the orientation. Okay, aortic valve at 12 o'clock.
That's looking better right now.
Yeah.
Keep doing that.
Yeah, that's where the
We're right in the center.
Yeah, that's good there.
And okay, Prashant, let's go to the LVOT view. And what we're doing is when we're clocking, you maintain a forward, how you remove the tension from the system. Okay. Put color, Prashant,
that?
bicom.
That's the flail.
So I think
You go
anterior,
3D just
anterior
check
is
the
off.
orientation.
Let's go to the
The
3D
3D
again.
and
Yeah.
face. Lost the orientation. Go, let me see.
Orientation is, I think we are okay. 12 to 6.
Okay, yeah, sure.
Yeah.
Okay.
But we have come more posterior. Grasping view, please.
Pull the system or get a little M.
So I'll
Just
pull,
go present.
Tiny.
I'll pull back the system a little. Okay, let's see. Okay.
I'll do it.
So I'm going to pull back now.
Yeah. Very nice.
Drop the grippers,
Yep.
please. Okay, close the clip. You can
There.
see grippers bouncing.
Now you have that posterior.
Now you got posterior in.
Okay.
Yeah.
Wait.
Advance the clip a little so it doesn't slip out. Close the
Wait
clip.
a minute. Okay, close the clip.
What's
And-
happened to LA pressure?
I'll show you. Wait a minute. I just advance the clip a little forward just to get rid of the tension. And we're going to close it. Okay.
What is the LA pressure like? Can I see?
Yeah, can you see the tracings now, LA?
We'll look
So
at the
ele-
MR.
yeah.
There's no MR.
So there's
Are you closed all the way?
no. Can you focus on the hemodynamics? Just focus on the hemodynamics screen, please. Yes, that's
Oh,
the
yeah,
LA
look at
pressure.
that. We will.
Come down.
The
Great.
V wave was almost 50. Now V wave has come down to
Yeah.
30. So I'm going to close it further.
Yeah.
Yeah. And the systolic pressure may come up with this.
So systolic is already 120.
Yeah.
Okay. Now,
Close the clip. Let me-
now
can I see echo?
show the echo and hemodynamics both, please. Echo, hemodynamics, and fluoro.
Echo is more important.
Yeah, echo.
Yeah, we need to.
Very good. There's no MR.
Yeah. Just,
Now just interrogate the MR, Prashant.
Okay.
Go
Prashant,
back and forth. I don't see any MR, right, Prashant?
so
No.
evaluate the MR and also evaluate the leaflet insertion.
Leaflet is inserted very well.
and gradients and
Yeah.
3D and all that.
And the pulmonary vein, sure.
Okay, so there's no. See how the eccentric chair is gone?
Yeah.
Show me in bicable, the bicommercial view where the color jet's coming from. In bicommercial view. Yeah.
Go to the BICOM.
See, that's a commercial jet. See that? That
Yes.
doesn't matter. Great.
Yeah.
The flail is actually taken care of. Explain that.
Yeah, there is no plan.
Very good. The anterior jet is gone. Now let's do gradients and
Gradients and
pulmonary
pulmonary
vein.
vein.
Yeah, the LA
Radiant.
pressure is like the V wave is gone.
This looks great.
There are so many things we have to think about. With MitraClip, you need a TE. Can you do it or not, and what can you get? The other thing I would say in this case, one of the biggest things is
Careful.
what all the manipulations that were done in the left atrium to make sure the trajectory was right before you entered the LV. Because if you don't get that right and you had an aorta hugger, you would be struggling for hours, and you will get a bad result because the clip will be in an angle or something.
No, I
But then
agree.
all
Other thing which I was thinking, we should start getting used to the cautery and bovie for the puncture needle. So because the other time which we took was attempting to do a septal puncture, everything kept sliding. So I think what I'm going to do is I'm
Yeah.
going to start learning this electrifying the wire.
yes, just pull it out.
Okay, so I'm going to pull back the whole thing now. Okay. Prashant, show the septum, please.
Yep.
Okay.
Very nice. I'm
This is the
really,
club.
really appreciative of your case. It was really well done.
Thank you so
And I
much, Dr.
think
Sabalkar, and thank you, Kashish. Both of you made it a more educational.
You did a great job at every
Thank you,
step.
thank you.
This patient will really benefit from your expertise. So
Thank
great
you,
to be
both of
here.
you. Thank you, Dr. Kar, and thank you, Kashish. And I think
Yeah.
Dr. Chandra is back in his OPD, I believe. So thank you for
Yeah.
us from our side. Has Prashant on T, has Dr. Kailash, and has Dr. Govind, and the entire cath lab team. Thank you so much.